So, hello everybody, welcome to this, I've lost count of the number of webinars, let's say third or fourth. If you're not on mute, please can you mute? We've got a lot of background, thank you. And in terms of being a bit less distracting for everybody, could I ask that you turn your cameras off as well? Thank you. I'll turn my camera off in a moment once I've introduced our main speaker. So thank you for joining us. Emma Wilmot from Derby is going to talk to us about time and range. Lots of people know Emma, and she's been a consultant in Derby for a few years now and setting up the Diabetes Technology Network, and has been an advocate of Daphne for a number of years now. So welcome to Emma. As we get started, it would be helpful if in the chat you could say what your name is, if you're a nurse or a dietitian, and where you're joining us from. And then as we get going, myself and Becky Hedgecock from the Central Daphne team will be keeping an eye on the questions, and then we'll moderate the Q&A at the end of the session. The session is being recorded. When we record things, it does record everything in the chat, so don't write anything in the chat that you wouldn't want repeating. Okay, without further ado, I'm going to let Emma kick off. Thank you very much, Emma.
Thank you very much, Jackie, and thank you to everybody who's taken time out of their busy work or life to join us this evening. For really one of my favourite topics, which is time and range, and it's my favourite topic because it has fundamentally changed how I work in the world of diabetes, and I think it's changing how many people with diabetes approach their diabetes care as well. The Teams problem of the slides not going on, we're okay now. These are my disclosures. So we're going to start by looking at the International Consensus on Time and Range, which came out in 2019, and I'm sure it's probably familiar to a lot of people, but it might be new to some people that are logging in. We're then going to think about how we use time and range as a concept to help us support people to achieve optimal glucose levels. And we're also going to think about how we interpret glucose data. But I'd like to start by really recognising where we've been and where we've come to with Daphne Structured Education. In 2020, we celebrated 20 years of Daphne Structured Education courses. And by that point, we delivered over 7.8 thousand courses to over 52,000 graduates. Now, we know that Daphne is associated with a reduction in HbA1c, but actually there are even more important reductions in DKA and severe hypoglycemia. And we know that those who have impaired awareness of hypoglycemia can sometimes reverse this loss of awareness through attending Daphne. But most important, it's associated with improved diabetes related to stress. And before I go on to the next slide, can I just check that everybody is on mute as there's some background noise coming through? Thank you. So I think for any Daphne educator or any person living with diabetes, I think we all recognise the challenges of living with type 1 diabetes from day to day. The pressures are huge, the workload is huge. That constant planning and thinking ahead, the need to check glucose levels frequently, the calculating insulin doses, correction doses, taking into account all the factors that influence insulin requirements such as stress or exercise, that very real worry about hypoglycemia from a day-to-day basis, and that longer-term pressure to constantly be reviewing data and striving for improved glucose levels. And not to forget counting carbohydrates, the most challenging part of type 1 diabetes. I think if we were to ask everybody in this call today how many carbs were in a plate of pasta, we'd all probably come up with a different answer. And this just adds to the complexity, doesn't it? But I think we need to realise that when we're striving for optimal glucose levels, there is a balance to be struck. Yes, we need to achieve great HbA1cs, and that's ultimately what we're aiming for, but we need to balance that against the lived experience of the person with type 1 diabetes. And actually, this is what Daphne really strives to do, to help people reach their goals but also taking into account all the other factors in life. And I think looking back, we are very guilty of striving for HbA1c targets to reduce the risk of complications from diabetes, but unfortunately, historically, that has often been at the risk of increased hypoglycemia. And hypoglycemia matters because it impacts on the day-to-day living with diabetes. We're increasingly aware that the ups and downs in glucose levels or glycemic variability can also have an impact on the person living with diabetes. And actually, although HbA1c has got an established role in diabetes care, it is actually quite a crude marker of glucose levels. So here are data from two different individuals, so let's have a look at what they show. On the left-hand side here, we've got HbA1c of 69, but 13% time below range, or time in the hypoglycemia range. And you will notice here, looking at the dense red area there, that we can see that most of the hypoglycemia is occurring overnight. Compare that to the case on the right-hand side. Same HbA1c, but interestingly only 1% time below range, or 1% in the hypo risk. So the way we'd approach both these cases is very different. Getting rid of the overnight hypos is the priority on the case on the left, whereas improving time and range is the priority in the case on the right. And I think these two cases very much highlight the fact that HbA1c provides limited information about the approach to the glucose data and what changes need to be made. So two individuals with the same HbA1c can have markedly different glucose profiles, markedly different glycemic variability, and markedly different hypoglycemia risk. But in the past, we've just simply not had an easy way to measure these. So where are we with HbA1c? Well, it's definitely got a lot of pros. It is very much an established marker of glucose control. We know that higher HbA1c is associated with complications, and HbA1c is relatively inexpensive and is very much embedded in the clinical care that we all provide. However, the downsides are it does not tell us any information about what the glucose levels are doing on a day-to-day basis. But more importantly, it provides no information on the risk of hypoglycemia. But fundamentally, it does not tell us what we need to do to improve glucose levels. So we desperately need a better way forward. Well, I'm sure that you are all familiar with the very rapid rise in Freestyle Libre prescribing in our country. And we're now at the point where nearly 1 in 3 people living with type 1 diabetes has access to Freestyle Libre. So this device, which gives access to continuous glucose data, has really changed our approach to diabetes care. On the left-hand side, we see the sort of images that we often see when we start people on the Libre, and we see these ups and downs in glucose levels that people perhaps would not have been quite as aware of prior to going onto the Libre. And what they are able to do is learn more about their diabetes, work to optimise their insulin and their behaviour to move to the right-hand side where hopefully the peaks and troughs are less marked. But using this technology has brought new opportunities, and that's a new opportunity in terms of time and range. So what is time and range? Well, put quite simply, it's just the percentage of time that the glucose values lie between 3.9 and 10 millimoles per litre. And here you see a few days of glucose traces, and you can see there's some glucose levels falling within that range and other points in the day where they're running higher. Now, through having more access to Freestyle Libre and other continuous glucose monitoring systems, we now have standardised reports across all systems, which makes it easier for us all to look at the data in the same way and very quickly get to grips with what's going on. What you see at the top right here is time and range, and in this instance we can see 45% time and range with 0% time below range. We also have information on the glucose management indicator or predicted HbA1c, but most importantly we have the ambulatory glucose profile here at the bottom, and we can see exactly what the median glucose is doing, which is a dark blue line in the middle, and then the quartile ranges, which gives you a visual display of where most of the glucose levels tend to lie. Now, if you haven't already, then I would highly suggest that you familiarise yourself with this international consensus statement from Taji, Battaglino and colleagues. So with the increased access to continuous glucose monitoring, they got international experts together and came up with some recommendations about the best way to interpret that data, and this is the international consensus. Now, I could sit here and tell you what the international consensus is, but actually I'm going to give you a bit of a challenge. Now, there's some of you that this will be familiar to you, there's others that may not. So the question is, the recent international consensus for glucose time and range recommend that which percentage of glucose value should fall between 3.9 and 10 millimoles per litre? Is it 1, more than 60%, 2, more than 70%, or 3, more than 75%? So congratulations to those of you who went for number 2. The answer is indeed more than 70% time and range. However, very important to stress at this point, like everything in diabetes, it's very much individualised targets depending on where the person's time and range currently is and what they would be comfortable aiming for. But the international consensus is that we should ultimately be aiming to get to more than 70%. So what does that actually mean? Well, as a sort of rule of thumb, generally we're talking about an increase in time and range of 10% being associated with a reduction in HbA1c by around 5 millimoles per mole, or 0.5% if you prefer working in old money. And what does time and range mean in terms of complications? Well, they've gone back to the Diabetes Control and Complications trial from the 1990s and looked at the data that they collected there, and admittedly that was from blood glucose data, but they've looked at the association between the time and range from that 7-point profile blood glucose data and the subsequent risk of complications. And they found that a 10% increase in time and range was associated with a 40% reduction in microalbuminuria and a 64% reduction in retinopathy. But actually, time and range doesn't just matter for healthcare professionals. This survey done by Diatribe looked at things that have a big impact on daily life for people living with diabetes. And what was interesting was that time and range constantly came out top, well ahead of HbA1c. Now you might wonder why that is, but if we think about how we measure HbA1c, it's a blood test every 3 months. If we suggest an HbA1c target to somebody, it's very difficult to know whether they're achieving that target in between the blood tests. Compare that to time and range, which can be viewed on a Libre device, a Dexcom device, etc. And people can monitor how much time and range they're achieving, and they can see how it changes from day to day, week to week, month to month. So moving on to think about the international consensus and the other recommendations they make, what percentage of glucose values do they want in time below range that's less than 3.9? Are we aiming for less than 10% time below range, less than 4% time below range, or less than 5% time below range? So again, congratulations to everybody who opted for number 2. The answer is less than 4% time below range. So here we have overall the targets for people with type 1 diabetes and type 2 diabetes. So again, we've got that more than 70% between 3.9 and 10. So it's important to remember the target range is 3.9 to 10 and check that people are using that when they're reporting it in clinic, particularly in the world if you're doing telephone clinics and if somebody's not been able to upload their data and they're verbally reporting it, you want to make sure that that's the range they're reporting on. But finally, we have a metric of therapeutic success that measures hypoglycemia as a key outcome. And I think that this is fantastically useful in day-to-day clinical practice. Because let's be honest, every person living with diabetes is keen to have their glucose levels where they want them to be. But the reality is that it can often be tricky to achieve this without the very real risk of hypoglycemia. And hypoglycemia is a significant problem. It has a big impact on people living with diabetes. It impairs function, it can stop them in their tracks at work, and it creates fear. And sadly, 1 in 3 people with type 1 diabetes go on to experience an episode of severe hypoglycemia per year. And when we're discussing severe hypoglycemia, we mean hypos that are so bad that they need either, a relative or paramedics out to treat it because they're unable to treat it themselves. So now we're able to measure time in hypoglycemia and really try and reduce the risk of hypoglycemia and subsequently reduce that risk of severe hypoglycemia. Now, of course, there are some people where we are particularly concerned about the risk of hypoglycemia. And with this in mind, the international consensus have developed separate recommendations for the older and high-risk individuals. So for this group, the recent international consensus for time in range recommends which percentage of glucose values and time below range which is less than 3.9. Is it 1, less than 5% time below range, 2, less than 3% time below range, or 3, less than 1% time below range? And the answer is number 3 this time, less than 1% time below range. And the reason for this is really to make sure that this group with a higher risk from hypoglycemia have an absolute minimum experience of hypoglycemia. And 1% equates to 15 minutes in a day. Whether somebody falls into that older or high risk group is again an individual discussion to be had with that person with diabetes, depending on their targets that they are comfortable with. And again, the one thing that's different with the high risk category is that here we're aiming for more than 50% time in range. Now again, this is so important to individualise. There are some people, particularly long-standing diabetes, who have been really strive for very tight glucose levels to minimise the risk of complications, and they may not be comfortable with 50% and want to strive for higher than that, and that's absolutely fine. The main thing here is really looking at the time in hypoglycemia and getting it down as low as we possibly can. For anybody who works in an antenatal clinic or anybody who's contemplating getting pregnant or who has type 1 diabetes and is pregnant, it's worth highlighting the separate recommendations for ladies with type 1 diabetes who are pregnant. So the first thing to point out here is that this is one instance where the target range changes. Here the target range for glucose levels are 3.5 to 7.8. Now you may be saying 3.5 is a bit low, are we worried about this? But actually Professor Helen Murphy, from her trials that she's done in type 1 diabetes and pregnancy, is quite confident that going down to 3.5 when you're type 1 and pregnant should be relatively safe. But here again, we're looking for less than 4% time below range, but the cutoff for time below range is less than 3.5. And as soon as a woman gets pregnant, we want to support them to achieve as much time in that 3.5 to 7.8 range as we possibly can. So when it comes to the clinical practice and checking time and range settings, I thought I'd just very quickly walk you through. So as I've mentioned, for most people with type 1 and type 2 diabetes, the time and range setting is 3.9 to 10 millimoles per litre. So what does that mean in clinic? Now again, there's different devices available, but I think in the UK, the majority of people are using the Freestyle Libre as access to continuous glucose data. So at the top right of the app on the phone, they can go into account settings, report settings, and make sure it's set at 3.9 to 10. And again, really important, if somebody's not able to upload at home, that they check that this is a setting if they're giving you a verbal report on time and range. So how do we go about improving time and range? The key question. So the one thing through using the Freestyle Libre that we've recognised is that people, when it's easy to access glucose data, tend to do it more frequently. And the national audit that I've been involved in from ABCD suggests that most people are scanning 13 times per day. If it's easy enough to just drop in and see what your glucose is doing, that's what people tend to do. And it tends to predict lower HbA1c the more scans people do. But we also know from other data that there are a number of factors that are associated with lower HbA1cs, and these are things which are all very common concepts for DAPHNE educators and teams. So having the bolus before the meal, again, something we would all advocate. Trying not to miss insulin is equally important. And interestingly, different insulin to carbohydrate ratios at each meal. And I guess this reflects looking at what's happening and thinking about what ratios are needed for each individual meal to help optimise the glucose levels. So I'm going to spend a bit of time thinking about the bolus insulin and the basal insulin and how we can use the continuous glucose data to help optimise that time and range. So for the bolus insulin, the idea is that if the individual's insulin to carbohydrate ratio is correct, that glucose level should go up and return back to the target level within 4 hours. Now, if this was the trace that we got every time somebody ate carbohydrates, I think we'd all be out of a job, and people with diabetes would never need to see a diabetes team ever again. Unfortunately, it's definitely not that straightforward. But thinking about the general patterns that we see, this is an example of where the insulin to carbohydrate ratio is too low, and we see that the glucose level goes up after the person's eaten, but it doesn't come back to the target level. And if this is a persistent pattern, it suggests that the mealtime insulin to carbohydrate ratio will need to be changed. Another scenario that we can sometimes see is if the insulin to carbohydrate ratio is too high and there's too much insulin given at mealtime, that you see less of a peak and then later postprandial hypoglycemia. Remembering that the rapid-acting mealtime insulins tend to last for around 4 hours, so any hypos within that 4-hour period are likely to be related to the bolus insulin, so look out for that pattern. Now, ideally, as I mentioned, we want to be giving the mealtime bolus before food, and bolusing 15 to 20 minutes before meals is extremely challenging for people to achieve. But if they can, then it does really help minimise that postprandial peak and, importantly, the risk of late hypoglycemia. If you see on the right-hand side here, if somebody gives their bolus insulin after a meal, it means that the glucose has gone up from the carbohydrate before that insulin's had a chance to work, and that insulin will be lasting a bit longer than ideally wanted, and you can see you get a risk of late hypoglycemia here. So if possible, bolusing 15 to 20 minutes before is ideal, but we do recognise that this can be very challenging for people to achieve. The best time of the day that a lot of people find is easier to plan is typically around breakfast. You know, I think most of us have a routine for getting up and out the door in the morning. And if you can build in that bolus at a time that you know is roughly 15 to 20 minutes before going to eat, that can be quite useful. And then correction doses. So correction boluses should ideally bring a high blood glucose back into the target range within 4 hours. But of course, the corrections can lead to problems. So here is one example. So in this instance, the person's got up in the morning, they've not had any breakfast, they've noticed their glucose level's high, and they've given a correction dose of insulin. But we can see that the blood glucose has dropped from 15 to 2.5 millimoles per litre, and that suggests that the correction factor is too aggressive. So when we're looking at Libre data and looking at hypos, have a look and see, are they tending to occur after the correction doses are given? And if they are, that suggests that the correction factor is too aggressive, and that's something that we need to address. And another thing, and this is particularly relevant for those that are just starting out on the Freestyle Libre or CGM, is insulin stacking. So when people start using the system and they're suddenly seeing big peaks in their glucose after they've eaten, there is this huge temptation to throw more insulin at it, just get that peak down. But of course, then you lead to a situation where you've got insulin stacking. That first insulin dose will be lasting for 4 hours or so, and if you give another dose 1 to 2 hours after it, then you will end up with a lot of insulin around in the hours after that, and with the risk of hypoglycemia. So if possible, try to correct before main meals and before bedtime as the safest time to give a correction dose. And again, we're expecting that to bring it back to target around 4 hours later. And if possible, try your best to try and avoid a situation where we've got insulin stacking occurring. So moving on to consider some of the issues around basal insulin. So again, here is the ideal situation, which if this happened every night, we'd all be out of a job and every person with diabetes would never be seen again. So here we are looking for the basal insulin is great, and we've got a nice steady flat glucose profile overnight. And that is the ideal situation, but again, almost certainly never happens 2 days in a row for most people living with type 1 diabetes. In contrast, here is a situation where the basal insulin dose is too low. So if you see that gradual creep in the glucose levels and it's rising gradually overnight, then we know that that's an indication that the basal insulin dose is too low. Now, of course, you need to take into account other factors that affect insulin sensitivity. It may be if somebody's unwell, for example, they might see this pattern. So think about temporary issues that might cause this pattern. But if it's a recurrent ongoing issue and there's no more acute causes for this pattern, then we may need to increase the basal dose, typically by around 10%. In contrast, here's an example of where the basal insulin dose is too high. So if the glucose is gradually falling overnight, and that's happening every night with no other cause, there's no alcohol or exercise, etc., contributing to that, then that's an indicator that the basal insulin dose is too high and will need to be reduced down. And another thing which is extremely challenging to manage, and actually we probably recognise it far more often now we've got access to Libre data because we can see exactly what's happening overnight, is the dawn phenomenon. So when people get up in the morning, a few hours before they get up, their body chucks out all these hormones that basically push the glucose levels up, and this is the dawn phenomenon, and you can see it demonstrated here. So around just before 4 in the morning here, we can see the glucose levels starting to rise. So if you're seeing that and it's taking off from the sort of middle of the night onwards, then this is an indication of a dawn phenomenon. Like everything in type 1 diabetes, it's not as predictable as we'd like it to be. Studies suggest it happens around 50% of the time, but there are some people who have persistent dawn phenomenons night after night after night. But an important thing to recognise, because if you assume that the glucose rise from a blood glucose in the morning without the Libre data is just related to the basal insulin, and you increase the basal insulin, you increase the risk of hypoglycemia at 2 or 3 in the morning. So really important to recognise. A further scenario, which is quite common, but again important to recognise, is snacking in the evening. So if you look at these two glucose traces at the bottom, on the left we've got the evening, so you can see the glucose goes up after 6 p.m. at night, and then it stays up and takes off again after 10 o'clock at night, and then overnight the glucose levels are stable. Now, if we were to increase the basal insulin, actually the basal looks okay, the glucose levels are steady. The issue is the snacking before going to bed at night that's keeping the glucose levels up. So this is more about making sure we cover the carbs in the snack rather than adjusting the basal. And again, this is a pattern that you can pick up on these Libre traces quite often. But I think the reality is, and again, the research studies have shown this, that anything is possible in type 1 diabetes. Glycemic variability is an inherent part of type 1 diabetes, and whether you're a healthcare professional or somebody with diabetes who's logging in to listen to this session, you know, the ups and downs of diabetes are there, and all we can do is firefight to try and control these fluctuations, but don't beat yourself up if it's not possible, because this is the nature of the beast. So moving on to just consider some data interpretation, thinking about how we maximise time in range. I'm just going to show you some Freestyle Libre data, and we'll consider what's going on. So let me walk you through this data here. So on the top right, if we start with the time in range, we can see there's 45% time in range and 0% time in hypo. So we can instantly see that this is somebody who's wanting to increase the time in range. Hypoglycemia isn't such a problem. We can see the GMI, or glucose management indicator, shows an HbA1c of 8.2 or 66 millimoles per mole. And then if we look at the bottom, the thing that jumps off the page at you here is that rise in the glucose after breakfast. We also notice that the glucose actually tends to drift down overnight, again raising question marks about the basal insulin. Now, from the AGP, I use that as my hypothesis generator, so you're looking at it and getting some ideas about what you think might be going on. But of course, it's so important to get the story from the person with diabetes, and also to look at the daily traces just to sense check together whether what you assume to be the case is. So here we can see that if we start with the basal and look overnight, there is the impression of a gradual drift down from 10 to 7, from even higher down to 7. So there's a question mark here about whether that basal insulin may be a little too aggressive, but actually the key problem here is the rise in the glucose after breakfast, And as I showed earlier, that glucose is staying up and not coming back to target. So again, this indicates that we need a more aggressive insulin to carbohydrate ratio at breakfast time. And then to see the main points that this slide shows. So here, if we start at the top right, we've got a target range of 62% time in range, so pretty good. But when we look at the time below range, we have a total of 18% time below range. Now you'll recall that the international consensus is aiming for less than 4% time below range, so this is really quite high. We've got the glucose management indicator of 6.4 or 47 millimoles per mole. And then at the bottom, we've got this ambulatory glucose profile, which helps us very quickly eyeball and identify the greatest risk of hypoglycemia. And what we can immediately see is that the greatest risk of hypoglycemia tends to be overnight. And the suggestion would be that that's probably going to be related to basal insulin. Now, don't get me wrong, you can get hypos overnight related to correction doses before bed, but I would hypothesize that this is probably related to basal insulin, given that the glucose is generally in the target range before they go to sleep. But again, you'd want to sense check that with a person with diabetes and look at the daily traces together. But hopefully we're very quickly able to take that high time below range and convert that to time in range, and then this person is going to be well above 70% time in range if we can correct that hypoglycemia. And here is an example of the what I discussed earlier. So let's start systematically. We start at the top right. So time in range is 55%, time below range is 4%, and the GMI is 7.5 or 59 millimoles per mole. But what you'll see when you look at this ambulatory glucose profile, the thing that jumps off the page is that significant rise in glucose during the morning. And we can see that the interquartile ranges are relatively tight, so this is something that's happening day after day to this individual, the same rise in glucose that's taking off in the middle of the night. And if I show you the daily traces for this one, so if we think about the principles of looking at the basal insulin and whether it's optimized or not, so on that Saturday the 5th of September, you could potentially convince yourself that that was a basal problem and we need more basal because it's just a gradual rise. But I think when we look at the other days, you can see that actually the glucose is quite steady until sort of 4 o'clock in the morning or 3 o'clock in the morning, and then starts to take off, suggesting that this would be more compatible with the dawn phenomenon. And actually these traces here really start to show you the risks that we pose with the dawn phenomenon. We can see here that you've got some nocturnal hypoglycemia coming in on these 3 nights, but there's still that rise. So some people have asked me, well, the rise in the glucose after a hypo is Somogyi effect, is this not counter-regulatory hormones coming out from hypoglycemia and sleep? But my colleague, Dr. Pratik Chowdhury, or Professor Pratik Chowdhury, has done some work in this area and has suggested that the Somogyi effect, which basically means glucose rising after an overnight hypo, is actually a myth and doesn't happen. It tends to be that if you have a hypo overnight, that you're more likely to wake up with a glucose that's still in the hypo range or low. So this would be fitting with dawn phenomenon also. And I think the treatment options in this instance often tend to be related to insulin pump therapy, where we can tailor the insulin delivery to increase during those hours and tackle the dawn. So I've really sort of very much rattled through some of the principles of optimizing Freestyle Libre and other CGM devices, but myself, Jackie, and many other members from the Daphne Executive Board have been involved in this Diabetes Technology Network online education portal, where you can access a range of modules covering many topics, and these are available to freely view for both healthcare professionals and people living with diabetes. Now, I'd particularly like to highlight the module from Parth Narandon and Rob Andrews. I don't know about you, but I think that exercise in type 1 diabetes continues to be really challenging, and they've put together a 30-minute online module that you can just direct people in the clinic, or if you're a person with diabetes logging on, I'd encourage you to go and have a look, because there's certainly some really useful advice in there. There's also sessions in glycemic variability, hypoglycemia, etc. So please do have a look. But I'd like to finish where I started. I'd like to congratulate all involved in Daphne for 20 years of delivering Daphne both nationally and internationally. And I've added in a quote from one of the people in my service who very recently said to me, the Daphne course has changed the way I feel 100% and has had an amazing impact. And that really is to feedback that this is not just about HbA1cs or time in range, it's actually about striving to give people with type 1 diabetes a better life, and I very much believe that that's what Daphne does. So thank you to all who have been involved. So Chair, ladies and gentlemen, in conclusion, time in range is a new measure of therapeutic success, and we're able to utilise this with the increasing use of diabetes technologies. I'd argue that time in range is more accessible than HbA1c, it doesn't need a blood test. I like the fact that you can use it for self-monitoring of time in range daily, weekly, monthly. But most importantly, it allows personalised targets and it highlights the hypoglycemia risk, which is a very much a concern for people living with diabetes. And we finally have a metric that really measures it and gives feedback on that as an outcome measure. So thank you very much, and I'll hand back to Jackie, and I'm happy to take any questions if you post them in the chat. Thank you.
Thank you, Emma. That was really excellent. So I'm getting some feedback. We've not had any questions in the chat because everybody's been listening so very carefully. So can I kick off? While people are having a think, please do put your questions in the chat box. On the AGP report, you talked us through it very nicely and gave people a systematic way to look at time and range first, and then percentage of hypos, the GMI, giving us an idea of the HbA1c. Could you just talk us through the CV and the significance of the CV? Because that's the other number on there that people won't be so familiar with. But you know, it's really helpful, I think, with your hypo example. If you wanted to bring up the hypo example, just to help illustrate that point.
So where are we? So this one here, Jackie?
Yes, please. Thank you.
I'm just trying to get that full screen. Yeah, so the international consensus is recommending that we measure glycemic variability and that we're aiming for less than 36%. Now, you might ask, why is glucose variability important? But if you look at the research studies that have looked at this, glucose variability is very closely associated with the risk of hypoglycemia. And the way I very simply think about this is that more that your glucose levels are going up and down, up and down, up and down, the greater the risk that that's going to end up falling into the hypoglycemia range. And we can see that in this individual, we've got quite a lot of glycemic variability there at 48.6%. Now, I'd be interested to hear your thoughts, Jackie, but I have to admit that in clinical practice, I don't actually tend to discuss that figure as much, because I feel that actually eyeballing the ambulatory glucose profile just feels more meaningful in terms of being able to see the distribution of glucose levels. But yeah, so if you are wanting to discuss it or use it in clinic, less than 36 is what we're aiming for. But for me, measuring time below range, which is ultimately what glycemic variability is a risk marker for, it feels far more clinically relevant for the person with diabetes.
Yeah, I agree. You've got kind of two things. The main point about the variability is we know that it increases the hypo risk. And then when you're trying to convince people to do something about their hypo risk, I guess if that one at 48%, you would see both coming down at the same time. So it gives you a number to illustrate how wide those blue and grey bars are. So next time when you look, you're thinking, okay, those blue and grey bars look narrower, but it does give a measure, a quantity of that, doesn't it? But also on the reverse of that, I sometimes use that to reassure people that in fact their amount of variability is fine. So, you know, as you pointed out with the survey, lots of people really hate the variability in glucose, and all of a sudden the Libre, they can see more variability than they ever thought they had before. They were having it for years, they just didn't know about it. But then if somebody's got a CV of 34, I'm saying, well, actually, you've got very little variability. Anything below 36% is really good. Actually, that is good. You're not going to get it much lower, you know. So don't worry about trying to get that variability number lower, as long as you're not having hypos. Anything below 36% is really useful.
Yeah, and I think you come back to an important point. I think one of the most important things, because we now can see absolutely everything in, with this data. There's a reason why people used to come to clinic without their diaries or without their meters, and that's because people are worried about being judged. And actually, when you're using the Freestyle Libre, there's no hiding. So I think as healthcare professionals, we need to be very aware to the fact that people are literally letting us have insight into everything in their life, because everything they do in life impacts on diabetes and vice versa. And so I think we have to be very careful about how we manage. If you look at somebody's Libre data and went, wait a minute, your glucose is 20 that day and it stayed there all day, what on earth were you doing? They're not going to come back and share their data. So please be very sensitive to the fact that it's quite a big deal for people to share that amount of information. And also celebrate every little success. Somebody was at 30% time in range and they come back and they're at 35% time in range, that's fantastic. If they were scanning 3 times a day and they come back scanning 5 times a day, that's a fantastic achievement as well. So it's just recognising the amount of work that's going on for every person living with diabetes.
Yeah, and I know this is something that you would advocate as well, that when you're looking at the daily logs, to actually find a really good day first before you're talking about, oh, you need to increase the breakfast ratio, but just talk about find a good day and say, oh, last Wednesday was really good, what were you doing that day, and just chat about something where things were going well, and then they'll be a bit more open to be talking about the days where things are not going quite so well. But you're right, we have to be so careful not to judge just based on those traces, because we obviously have a lot of insight as to what might be happening, and that will be a bit uncomfortable for some.
And I think as well, what's fascinating is if you say to people in clinic, or over telephone or video conferencing, however you're doing your clinics at the moment, is say to them, right, look at this data with me and tell me 3 things that are really good about it. And they're stumped because they're so used to coming to clinic with a list of things they must do better. So if we can somehow move away from that and help them to recognise the things that are going well. We want people to enjoy engaging in the diabetes clinic and not feeling like it's just coming for a list of things they must do better.
Definitely. Always a job to make people smile as they're leaving. Okay, so we have a couple of questions now. So Carla is a dietitian with me in Sheffield, is asking if people are doing blood glucose checks rather than using Libre, what's the minimum number of checks a day that would give helpful time in range data? So if you haven't got any CGM, because not everybody's on CGM or Libre yet, what do you think would be a useful number of checks before we could use time in range?
So
it's not time in range, it's percentage of readings in range.
Percentage of readings. I mean, I think Pratik Chowdhury's done some work on this. I think the bottom line is the more glucose checks you've got, the better, but they'd ideally need to be done at the same time of the day throughout that period to be able to compare it from one time to the next. And also postprandial tend to vary a bit more than pre-meal. But I think Pratik's work, I believe, was 5 checks a day. I'd need to check that. But it's definitely easier when you're looking at continuous glucose data than just blood glucose data.
Yeah, I mean, I guess, like you said, it needs to be similar times a day, but it needs to be pre-meal. So the most important thing would be, comparing like with like. So always pre-meal and before bed, in order to have a good idea about that. And also, Carla said, well done, an excellent talk. So. Okay, and then next question, is time in range directly proven to decrease microvascular complication risk in an RCT? I think you kind of answered this, but if you just wanted to clarify.
Yeah, so the ideal scenario would be that we did a trial where everybody had CGM and we repeated the DCCT trial and had a look at the time in range with complications. That trial will never be done, it's way too expensive. And so what they've done is they've taken the DCCT data and looked at the actual blood glucose profiles, and that was 7-point profiles, and they've looked at the time in range from blood glucose to look at the relationship with complications. And that's probably as good as we've got it, and it's probably not going to get more substantial evidence than that. There are also data from people with type 2 diabetes that's looked at 3 days of CGM data and linked that to mortality in people with type 2 diabetes. So yeah, there's data there, but it varies. And I think the other thing that I'm increasingly recognising, I'm sure Jackie is as well, is the downsides of HbA1c. You know, there's such variability in how well HbA1c reflects glucose levels from one individual to the next. And I think actually, if you think about what HbA1c, it was a surrogate marker of glucose levels because we didn't have any better measure. Whereas now we've got a fairly good way of measuring glucose that gives far more detail. But time and range is very much here to stay. I'm not arguing that it should replace HbA1c. I think it complements it and we should be using them alongside each other.
I think you're right, we will be using it alongside. It'll be a long time before time in range takes over from HbA1c because the hardest data about complications is related to HbA1c, but we might end up with dual reporting in trials in type 1 diabetes and type 2 because, as you said, there are some people for which HbA1c is not a good marker. So we might have assumed, and I am guilty of this, of somebody that I don't know why their HbA1c is not better. They're working really hard, but their HbA1c is 71. And then you have a look at their time in range, and in fact, their time in range is quite good. So that tells you then that you need to have another think about why their HbA1c is higher than you were expecting. And so, I found 2 or 3 patients where they're actually deficient in iron, and I replace their iron, their HbA1c drops by 10. The time in range doesn't change very much, but they feel a whole lot better, and they're not so lethargic either. So as time goes on, I think people will get better at looking at the HbA1c and looking at the time in range and making sure that they do correlate. So thank you to Richard. So Richard is one of our people with diabetes, and he just said, I want to echo Emma's comment. I have no secrets with Libre, but there are things I may not want to be judged on. So it's really helpful, thank you. Okay, do we have any other questions? We're timetabled to be here till about 6:30, but obviously we are aware that this is outside of most people's normal working time, and Emma's done a double clinic, so she'll be happy to stay till 6:30, but equally she won't mind if we finish a few minutes early. While people are just thinking if there's any other questions, we do want these Daphne webinars to be helpful for you, and so they've been well attended so far, and we've had different people and we've done sessions with administrators, not just for our clinical colleagues. But if you've got any ideas as to what you would like webinars on, and even better if you can think of a good speaker to give us an idea, then we can approach these people and ask them to do a session. Okay, so we've got a question, the one that you thought might come up. What are your views on Libre 1, 2 and 3? So there's somebody here being very optimistic that we're going to get Libre 3 very soon. So this is Susanna who's signed in as a guest. Yeah, so Libre 2 is here, I believe, where I work in Derbyshire. We can't prescribe it until the start of February. But for those that aren't familiar, the Libre 2 is essentially like Libre 1, but it comes with a couple of benefits. The first and most obvious one is that you can set alarms for high and low. Those are optional alarms, but I think that will certainly help give a lot of people some reassurance to know that there'll be an alarm going off if their glucose levels are down low. The other one, Abbott have published a paper suggesting that Libre 2 is more accurate, so that hopefully will improve performance compared to Libre 1. In terms of Libre 3, I believe that this is going to be more like a proper continuous glucose monitoring system with alarms, but also closed loop capability is my understanding. I have no idea when that's going to be launched, but the way I look at it, the more technology that we have available, the better. So I look forward to hearing more about the Libre 3 in time, but certainly Libre 2, hopefully people across the country should be starting to get access to that now. And just for people on the call that may not be quite as familiar, Emma, could you just explain the difference between having a threshold glucose alarm like on Libre 2, which the low alarm can be set between 3.3 and 5.6, I think, as opposed to a real-time CGM system? Yeah, so for those that are used to using real-time CGM, so for instance, you'll know that Dexcom have got an alert that goes off as the glucose levels are dropping. In contrast, Libre 2 will only alarm when they reach the threshold that they set it at.
So I think you'll probably want to think very carefully when people are going across onto this about what level of alarm for loads that they'll be comfortable with. Now Jackie and I were discussing this, and we think that probably 4.5 will be a nice setting, because at least they'll get an alarm. Because we're saying that a lot of the time people aren't necessarily going straight along at that level. It's often a drop, so at least then they're aware that they're getting to that level. But again, that will vary from one person to the next. And then in terms of high alarms, my personal preference is, certainly when people are starting out on new systems, is to keep the alarms off and then introduce them at a level that they're comfortable with. But again, this will vary very much from person to person, and it will be ultimately what the person with diabetes that's using the system is most comfortable with. I don't know what your thoughts are, Jackie.
Yeah, and Susanna's raised a good point. So she's able to prescribe it in Manchester, but also said that some patients already are not keen on the audible aspect. So if you end up with too many alarms, then that is really irritating. So you know, I remember I was so excited when I got a bleep of my own, and guess what, within a week you're just thinking, blimey, that bleep is too much. So I agree, you know, it's a really good idea just to set the low glucose alarm to begin with and help people reduce their hypos. And then if they want to set a high alarm, is to actually set it quite high. So as a group, we were discussing the other week that really you don't want the alarm to go off more than once a day. Otherwise it stops being an alarm. If we, you know, if we always have fire alarms going off, we ignore them. Whereas if a fire alarm does go off in our diabetes centre, then we're thinking, not heard that for a while, need to do something about it, and that's what it needs to be. So make sure that they are set quite high. You don't want it to go off just with a postprandial peak, because if they're not really buzzing 15-20 minutes beforehand, people are going to get a rise of 5, 6, 7 millimoles anyway, and you don't want it alarming just when it's doing that, and then you know it's on the way back down anyway. Okay, so there's a comment here. Some patients have very high postprandial sugars at 2 to 3 hours, and then it drops too low if they increase the insulin to carb ratio. And I think you showed a slide that illustrated that as well. So how can people reduce that postprandial spike?
That's lots of potential answers here. So I think the first thing is to look at the timing of the insulin and making sure that they're managing to pre-bolus so that it's actually the insulin's getting in at the right time. And the other thing is to look at the glycemic index of the foods and looking at what they're consuming. You know, we know that, for instance, liquid carbohydrates are going to hit very fast and cause peaks compared to lower GI foods. The other thing also is to 100% make sure you're comfortable that that basal insulin is where it needs to be, because if they're slightly under basal, then you will get peaks that are higher. So again, have a look at the overall profile, or perhaps ask them to skip some meals and see what happens to the glucose at that time of day. If they're not consuming carbs, because you may be able to optimize the basal at the same time as doing all the other things. And there are more rapid acting insulins that are certainly an option, and they're designed to be given at the time of the meal. But I think the reality is very much that every different meal causes a different profile, and I think one of the great things about having access to Libre or CGM is being able to look at the profiles in the glucose after different meals and learn about the impact that they have, because you may need one strategy for one type of meal and a different strategy for another type of meal. You got any other thoughts, Jackie?
Yeah, I'm just reminded to think about a patient that I reviewed in clinic last week, and we talked about being able to guess what people are doing with their Libras. You know, this is nothing too sinister, but I knew when she was walking her dog. So she was bolusing pre-meal at breakfast time, and sometimes that involved corrections and sometimes it didn't. But I said, okay, so, you know, you walk your dog Monday, Wednesday, Friday morning, but not Tuesday and Thursday. And it was just reminding her that, in fact, she needs to cut back on the bolus insulin when she knows she's going to walk the dog afterwards. So even having the correct insulin to carb ratio, that may need adjusting for physical activity as well. Okay, excellent. Nobody's come up with new ideas for your next talk, Emma. I'm disappointed. Perhaps we will. So there's a thank you here. Amazing lecture as well. Future talks, here we go. Helen Murphy to talk about pregnancy in Daphne graduates. Well, I agree, Helen would be perfect for that. She's always in demand and has been a good advocate for Daphne and can talk more about the concept trial. Rob Andrews on exercise. Depression management, yeah, Khalida Ismail, definitely. And then we've got also some clinical cases. So thank you, Dr. Eva, for suggesting all those. We'll go away and compose some nice emails to persuade people to do that. Okay, eating disorders and type 1, another hot topic. Always a difficult subject.
Yeah, definitely.
So for those people that's still on the call, just to let you know that we have been recording this. It will be available through the Daphne either website or portal within the OU. I should know the answer to that, but I'm afraid I don't. But we'll send you a link in case you want to share it with any of your colleagues within Daphne, within your centre. And also for the collaborative in the summer, obviously it looks like it'll be a remote meeting. And what I was hoping, Emma, I've not asked Emma this, but I was hoping that we could play the recording of her lecture at that time and then Emma be available for Q&A, and we'll also ask other speakers to be available on the day. So we'll send round details of that in the future. Oh, people are coming up with lots of suggestions now. So we have being menopausal or perimenopausal, autonomic neuropathy, so tricky, yes. We need a good speaker for that, Susanna, if you can come up with a name as well. Managing diabetes burnout. So we do have some good psychologists that we could approach that, don't we? Oh, losing weight with type 1.
Asking for a friend.
Yeah, of course, Richard. We have thought about that because there are some therapies used in type 2 that can be used in type 1 as well. So that's it. I think that is a really useful discussion. Great. And Becky has clarified what I should have known. She's going to put it on the website and on the OU Central Resources area. So thank you, Becky. Great. Okay. And another idea for dialysis and diabetes. Well, we also know who to ask to do that, don't we? So thank you. You've been excellent with all your ideas. And again, massive thank you to Emma. Really excellent talk. Excellent language throughout. So I hope that everybody has gained from that. And if your friends couldn't join, get them to watch it on the website or on the UU Web Centre. Thank you, Emma.
Brilliant. Thank you very much, Jackie. Thank you, everybody.
Take care. Have a good evening.